Hi everyone, this is Group 7, and this is our group project for Nursing 450. For our introduction, our project is based on patients with end-of-life care. For example, patients with cancer have the potential to receive enormous benefits with assistance in improving the quality of life when provided with palliative or hospice end-of-life care. For our position, therefore, the current requirements and structure of the Medicare and Medicaid hospice benefit should be re-examined in order to allow those with a terminal prognosis the opportunity to utilize that care. For our thesis, the 6-month prognosis requirement, the inadequate payment rates, and the need for quality assurance systems and patient education should all be addressed so that patients in dire need of end-of-life care can receive it as is appropriate on a timely basis. To recap, the 3 major problems are time requirement, financial issues, lack of information, and not getting the care expected. For getting care on time, individuals are eligible for hospice care if they have a prognosis of 6 months or less to live. However, most people don't receive hospice care until the final weeks or even days of life, possibly missing out on months of helpful care and quality time. An important note is that hospice care is always palliative, but not all palliative care is hospice.
Factors that delay hospice care: delays in discussing hospice care until patient is seriously ill or close to death, lack of communication between the patient and provider on illness and prognosis, delays in referrals to palliative and hospice care, confusion on the roles of healthcare providers, lack of coordination among healthcare providers, and confusion on which healthcare provider should initiate the discussion. Up next is Brenda.
Okay, so there was a study conducted in Taiwan that evaluated the effect of hospice on the survival and healthcare costs. There was pretty much 2 groups, a hospice group and a non-hospice group. The results of the study indicated that those in the hospice group had a longer survival rate, and their healthcare cost at the end of life was much less, 3.74 times much less than the non-hospice group. So this pretty much study shows that by reducing by enrolling in hospice care, it's much less expensive and their survival rate increases. So another study was aimed to see if the in-home hospice can increase patient satisfaction and also reduce medical care costs. So pretty much this study demonstrated that by enrolling in hospice care, patients increased their satisfaction and their medical care costs was decreased. And also they examined this study in particular extended the 1 year extended the requirement to 1 year instead of the 6 months requirement prognosis. And by doing so, patient satisfaction increased and medical healthcare costs decreased. So that's why it has been shown that by increasing it to 1 year, it can improve patient satisfaction and reduce medical care costs. So another study pretty much was done by the Palliative Journal Medicine, and this one demonstrated that there is a substantial amount of people that exceed the 6-month prognosis. This study indicated that there was 13.4 individuals of the patient population they studied that exceeded the 6-month prognosis. So pretty much the study demonstrates that there is a substantial amount of people that exceed that 6-month prognosis. So it doesn't fit the by extending the 6-month prognosis, it can accommodate a lot more people who need palliative care and hospice care. So that's why Medicare and Medicaid should reconsider the palliative prognosis requirement and extending it beyond that 6 months, and not just 6 months, because it would benefit a lot more people. Specifically, 13.4 individuals would have benefited from this by extending the prognosis requirement in this particular study. And lastly, research also demonstrates that patient teaching, there is a substantial lack of not enough patient teaching on palliative and hospice care. So this particular study interviewed 12 patients that were enrolled in hospice and 7 caregivers. And this pretty much study was demonstrated that there is a gap in knowledge that needs to be addressed so that patients in dire need of end-of-life care can receive appropriate quality care. So as healthcare professionals, we should educate the public and those people that are in need so they can get that care they need and eliminate the gap and increase the quality of care for hospice patients.
And as Brenda noted, there is a gap and lack of information. We have years of deficiencies in teaching end-of-life content in schools, so nurses are working without knowledge of how best to assist patients and families facing the end of life. Literature also has documented that nurses face ethical dilemmas such as conflicts about administering pain medication to patients at the end of life, communicating with patients and families, and nursing involvement in patient decision-making regarding withholding, withdrawing life-sustaining treatments. In an effort to reach these nurses currently in clinical practice, the End-of-Life Nurse Education Consortium, or ELNEC, investigators believed it was vital to train continuing education providers and staff development educators. This was launched in February 2000 to assist nurses in reducing the burden and distress of facing life's end and to offer support for the many physical, psychological, social, and spiritual needs of the patients and their families. And the methods of training are the trainer education course, mentoring, online palliative care education, and the annual granting meeting. The curriculum also assists nurses in reducing the burden. The curriculum that is in the LNEC consortium is nursing care at end of life, pain management, symptom management, ethical legal issues, cultural considerations, communication, loss, grief, bereavement, achieving quality care, preparation for and care at the time of death. Lesson learned in training. Education is essential. Start educating with individual units and then expand out to orientation and annual competency programs. There's a need for interprofessional team development. Collegial, collaborative, and communicative teamwork is essential, and working towards shared common goals is also necessary. Palliative care program should start small and focus on quality before any expansion. Ensure alignment between the palliative care program and the goals and mission of the organization. Discern key stakeholders and identify their needs. Use any and every opportunity to promote the palliative care program. And in patients' perspective, there's a gap in the literature that it tends to ignore the family context in which end-of-life decisions are most often made. Rettig, as noted in this family decision-making theory, indicated that individual decisions impact the lives of the family members with whom they share both financial and social psychological resources. The nature of an individual's decision environment includes an integration of economic and social psychological considerations. Since family is the primary context in which end-of-life decisions are made and implemented, it makes sense that the family decision-making theory, such as Rettig's family decision-making theory, be used as the guiding theory for the study. It's a theory that addresses the interpersonal dynamics and social decisions, which includes perceiving, deciding, and actuating the dimensions of decision-making. And using this core FDMT assumption and the theory's constructs, the purpose of the study is to explore factors related to a combination of medical and financial end-of-life planning actions taken by an adult child. And the next presentation is with Dina. Pass it on to you.
Thank you. Humanistic theory. Two models of health and healing include the body-mind connection and a more complex connection between the body, mind, and spirit. These theories are connected to the ideology behind being a human in the nursing environment. One must connect with human behavior, where the idea of acting as a human must be recognized in the core competencies of nursing. Next. Gene Watson, caring theory. Gene Watson introduced a caring theory that has become recognized as empowering and innovative in the nursing environment. Watson finds that there is a moral ideal recognized in nursing. Contact between humans, according to Watson, will help those who are ill discover new knowledge that can assist with the recovery and promote a healthier lifestyle moving forward. Adaptation. Nursing in an optimal environment demands adaptation. Watson's theory cannot be considered concrete in the nursing environment. Consider a patient who rejects spirituality. Professional presence demands adapting to the environment and meeting the needs of this patient, which means spiritual not being used as part of the healing process. Here, there is a disconnect between the theory that has been presented by Watson and the two models of health and healing, and professional presence that has been developed to best treat the patient and demonstrate humanity. And now, Erica Sanchez.
Okay, so I got the opportunity to interview a hospice nurse who's been doing hospice for over 6 years now. When asked about as far as eligibility, it wasn't a simple yes or no question, and she had provided a link to which you can access, and there's a lot of criteria that needed to be included before they could admit a person into hospice. What she also, as far as the difference between palliative and hospice care, she stressed that palliative is always part of hospice, and that the big misconception is that if someone's in palliative, then they're automatically in hospice, which is not the case. Someone with a chronic illness, serious illness, who's still seeking aggressive treatment, very much can benefit from palliative. Those are palliatives to help manage those symptoms that are caused by those illnesses. And when palliative turns in, or when hospice incorporates palliative, is when those treatments or for those illnesses are no longer being sought or no longer aggressive. Then when you're simply just managing, which is just palliative care, that's when it's hospice. As far as the finances and understanding the breakdown of Medicare, it was very intensive. A lot of factors that go into it. Every hospice company is different. She was stating that for the hospice company she works with now, they provide a lot of support as far as social workers, hospice aides, priests, chaplains, and then also kind of medical equipments that they need, and anything from like soaps to diapers, chucks, etc. But that previous hospice that she worked for in the past, they would provide bare minimum. So it's kind of hard to say, she said, to give you an exact number or where it works, because every company is different. As far as the funds, whether it's sufficient, she felt it's never sufficient. Of course, the companies themselves are trying to make a profit, but then they're also trying to give the most quality care they can for a patient. With hospice, it's not, because you're a hospice nurse, you're actually not with the patient 24 hours. A lot of the times these families have to take care of their loved ones on their own, or they have to hire caregivers, none of which is covered by Medicare or through the hospice. So it's just a support system as far as with hospice. And so it's never enough. They can always use more, but it just is a support. It doesn't cover everything that they may need. Medications is only covered what's to the actual terminal illness. So if they had, say, if they were diagnosed with cancer and they had hypertension, none of their hypertension would be covered. As far as the term about being over sedating, she took very offense to that. And if you were to read the slide, you'll see all her breakdown on that. As far as the nurse's role in pain management, she also, as far as different studies that I've read, there's lots of vital roles that nurses play, just in addition to pain management therapy that the doctors would prescribe. But nurses can educate the patients and the families and the caregivers on distractions, massage, spirituality, and then of course prescription medications, a lot of what they call comfort kits, which is standard medications they give that'll help when a patient is either suffering from severe pain or some type of respiratory distress or anxiety, all due to end-of-life situations.
For our action plan, we created a brochure. On this particular panel, you can see that I included some of the interview responses that Erica got from her hospice nurse. And to the panel right to the right, we have some of the benefits that it includes. On the other half of the brochure, we have the benefits of end-of-life care. And on the slide next to it, we have the differences of palliative and hospice care. In conclusion, if we just reduce the hospital service provided and instead we put them into hospice and palliative care, we basically save money and we improve the patient's quality of life at the same time. On our final thoughts, there are some barriers that we need to overcome, and to do this, there are two things we can do. We can formalize partnerships between hospital palliative care programs and community hospice programs. The second thing that we can do is, of course, educate the patients, families, and physicians about the availability and benefits of hospice and palliative care services. And then that is our presentation, and these are our references used. Thank you very much.